Good day, beautiful people. This is Dr. Culture. Like, follow, and let's get it. All right, today we're tackling amenorrhea. And look, this is way more than just a missed period. Think of it as a crucial symptom, a clue that tells us we need to do some detective work. So let's get into it.
Okay, first things first, let's get our terms straight. We basically split amenorrhea into two big buckets. You've got primary, which is when a young woman hasn't had her first period by age 15, even though she's developing normally otherwise. Then there's secondary. This is when someone who was having regular periods suddenly stops for 3 months or more. Getting this distinction right from the get-go is huge because it really shapes our entire diagnostic game plan.
And this is so important. We really have to shift our mindset here. A menstrual cycle isn't just about making babies. It's a vital sign. Seriously. Just like you check blood pressure or a heart rate, its presence or its absence gives us this incredible window into a patient's overall health. It's telling us a story about the hormonal command center, what we call the hypothalamic pituitary ovarian axis, or HPO axis for short.
So, to really get a grip on what can go wrong, we first have to appreciate the amazing, intricate dance of what goes right. Let's do a quick flyby of that HPO axis. Think of it as the body's endocrine orchestra, the conductor for the entire menstrual cycle. And this image here really brings it to life. What you're seeing is this super finely tuned feedback loop. You've got the hypothalamus up in the brain sending out signals to the pituitary gland, which then relays messages down to the ovaries. It's this constant back and forth hormonal conversation with checks and balances keeping everything ticking along in perfect rhythm. It really is a beautiful cascade when you think about it. It starts with the hypothalamus releasing GnRH in these little pulses. That's the signal for the pituitary to send out FSH and LH. Those hormones, they travel down to the ovaries and get things going, stimulating follicle growth and the production of estrogen and progesterone. And finally, these ovarian hormones work on the uterus, building up that lining which, if there's no pregnancy, gets shed as a period. A breakdown anywhere in that chain, well, that can lead to amenorrhea. All right, so now that we've got the normal physiology down, let's switch gears and talk about our clinical workup. This is where we put on our detective hats and figure out how to solve the puzzle, how to take a huge list of possibilities and narrow it down to the right answer. So here it is. The patient is sitting right in front of you. Their main issue? No periods. Now, the potential causes could be anything from something totally simple and normal to something way more complex. That's why having a system, a step-by-step approach isn't just nice to have, it's absolutely essential.
And that system always kicks off with a good old-fashioned history and physical. What are you asking? What are you looking for? We're talking about stress levels, exercise habits. Are you checking for signs of too much androgen, like hirsutism? What's their BMI looking like? Are there secondary sexual characteristics where they should be for their age? Honestly, the clues are so often hiding in plain sight, right there in that first conversation.
Okay, step 1. And listen, before you even think about ordering fancy hormone tests or imaging, this is the absolute non-negotiable first move. For any patient of reproductive age who comes in with secondary amenorrhea, you have got to rule out pregnancy. It is by far the most common cause, and you really don't want to miss it. Okay, once you've confirmed she's not pregnant, this initial set of 4 tests is your workhorse. It's your starter pack. You've got FSH, which helps us figure out where in that HPO axis the problem is. Prolactin and TSH, they're your screen for other common endocrine issues like prolactinomas or thyroid problems, which can totally throw the whole system out of whack. Seriously, these labs are going to help you categorize the problem and point you in the right direction fast.
All right, now let's talk about a classic tool in the toolbox, the progesterone withdrawal test, or PWT. The whole idea behind it is pretty simple. If the uterine lining, the endometrium, has been properly built up by estrogen, then giving a dose of progestin and then stopping it should trigger a period. It's a functional test, right? It tells us 2 things. Is there enough estrogen? And is the plumbing, the uterus and outflow tract, working correctly?
And reading the results creates this really clear fork in the diagnostic road. If she bleeds, that's a positive test. It tells you, hey, we've got enough estrogen and the pipes are clear. The problem is probably just anovulation, not ovulating, which is what we see all the time in PCOS. But if she doesn't bleed, well, that points to one of 2 big possibilities. Either there's not enough estrogen to build up the lining in the first place, or there's some kind of physical blockage. Okay, so let's take those initial lab results, specifically that FSH level, and use them to sort through our list of possible causes. This is how we get organized. This is how we go from a huge differential to a targeted diagnosis. So what if the FSH comes back high? This is a huge clue. A high FSH means the pituitary is practically screaming at the ovaries, trying to get them to work, but the ovaries just aren't listening. The problem isn't in the brain, it's down at the level of the ovary. We call this hypergonadotropic hypogonadism. It sounds complicated, but it just means high gonadotrophins, low gonadal function. The brain is trying, but the ovaries are failing. What could cause this? Well, in a woman under 40, we're thinking about primary ovarian insufficiency. And in a case of primary amenorrhea, we might be looking at something like gonadal dysgenesis, think Turner syndrome, where the ovaries just never developed properly to begin with. Okay, but what if the FSH is low or even just normal? Now our whole thought process shifts. This result suggests the ovaries are probably fine, they're ready to work, but they're either not getting the right signal from up top, from the brain, or there's a different kind of problem, like a blockage. And this bucket splits into a few really common causes. You've got your central issues coming from the hypothalamus or pituitary. The classic example here is functional hypothalamic amenorrhea, or FHA, where things like stress or low energy just shut down the whole system. Then you've got your eugonadotropic causes. That just means normal gonadotropin levels, where the issue is dysfunctional ovulation, and PCOS is the poster child for this. And last but not least, we have to think about those physical blockages, like Asherman syndrome. And look at that, we're right back where we started, the power of the patient's story. Their complaints can point you straight to the answer. Someone tells you about major weight loss, your brain should immediately think hypothalamic dysfunction. Cyclical pelvic pain but no bleeding, that screams outflow tract obstruction. This is exactly why that initial conversation is the most important part of the entire workup.
All right, enough theory. Let's put this whole framework to the test. We've built the algorithm, now let's see how it holds up in the real world with a couple of quick clinical cases.
Case number 1, we've got a 19-year-old elite marathon runner. She's got a low BMI, and she hasn't had a period in 8 months. Now check out her labs. FSH is low, LH is low, and estradiol is low. Everything's in the basement. So what's that pattern telling you?
This is a textbook, classic presentation of functional hypothalamic amenorrhea. All that intense exercise and the resulting energy deficit have basically put the brakes on her entire HPO axis, right from the top. It's technically a diagnosis of exclusion, but man, this clinical picture is a slam dunk.
Okay, next up, a 25-year-old, she's always had irregular cycles, but now she's come in with no period at all. The key things to notice are the clinical signs of hyperandrogenism, the hirsutism, and acne. Her labs show a normal FSH but a bumped up LH, and her ultrasound shows what we call polycystic appearing ovaries. And yep, you guessed it. The diagnosis here is polycystic ovary syndrome, or PCOS. You've got the ovulatory dysfunction, you've got the clinical signs of high androgens, and you've got the ultrasound findings. It ticks all the boxes. PCOS is incredibly common, and it's a major reason we see patients with secondary amenorrhea. So let's wrap up with this final thought. It's easy to think of FHA as just a fertility issue that'll fix itself. But the reality is that lack of estrogen has some serious long-term consequences for bone density and cardiovascular health, which leads us to a really critical question. How can we, as clinicians, get better at screening for and managing FHA before it causes that kind of long-term damage? It's something we all need to be thinking about. Thank you for joining this explainer.